Welcome to Module 3, an overview of skin disorders. Recognizing skin disorders is necessary to work with clients effectively and safely, especially for those conditions that are contagious or should be referred to a physician. Let's discuss a few conditions that properly trained estheticians or cosmetologists commonly treat: acne, rosacea, and hyperpigmentation. Acne that presents in lesions like papules, pustules, and milia can be effectively treated by estheticians. Gentle extractions can reduce the severity and frequency of those types of lesions. Always prepare the skin by double cleansing with light steam and use a de-encrustation emulsion before extractions. Remember to close the skin after extractions with a toner and application of a cold cleansing mask. Appropriate at-home skincare is vital to battle acne. Cleanser, toner, and moisturizer will keep the skin pH balanced and create a healing environment. Consider suggesting bi-weekly facial appointments for 6 weeks if your client's congestion is severe. This will help you make progress in clearing the skin faster. In severe cases, it may not be possible to extract every clogged pore in one appointment. This client should use a cleanser, toner, and lightweight moisturizer every day and night. It might be appropriate for them to use an antibiotic in conjunction with a retinol product. You may need to partner with a dermatologist for best results. Rosacea is inflammation of the skin that can be identified as redness, dilated blood vessels, and in some cases, papules and pustules. The esthetician's role when treating rosacea is to soothe and calm. Vasodilators that exacerbate rosacea include heat, sun, spicy food, and alcohol. Choose a soothing cleanser and don't use steam on this client. Apply a cold mask and use a moisturizer with aloe and/or allotonin. Keep your massage on this client short and light. Consider using LED light to reduce inflammation. You may need to partner with a dermatologist for best results, especially if their rosacea is inflamed. IPL light therapy is sometimes prescribed and can contribute to less redness. Rosacea is contraindicated for dermaplaning. Do not disrupt the pH balance of the skin type. It may take them longer to balance out, and we don't want to unintentionally add to long-term damage. Hyperpigmentation can be effectively treated by estheticians. In the clinic, use peels and/or laser treatments, if licensed, to pull up the overproduction of pigment. Daily use of at-home skincare that inhibits tyranase and exfoliates the top layers is crucial. Teach your clients to be consistent with their products and never leave home without sun protection. Sun and hormones are usually the culprit. Conditions that should not be treated by an esthetician and instead referred to a dermatologist include lesions like blisters, cysts, nodules, or tumors, skin cancer including basal cell, squamous cell, and malignant melanoma, disorders of the sweat glands, allergic dermatitis reaction like hives, irritant contact dermatitis, hypopigmentation, vascular lesions, and contagious disease. I want to introduce Dr. Michaela Overturf to the audience. She's a dermatologist based out of Nacogdoches, Texas. Thank you so much for coming to visit with us today.
Absolutely. I'm excited to be here. Thank you.
You're welcome. We're excited to have you because you're really considered an expert in our community. And so I wanted to really share that with other skin experts in Texas. And as an esthetician, there are so many times when I'm in the treatment room with a client and I think, I wish I had access to a dermatologist. Really the only time we're gonna have access to a dermatologist is if we book an appointment with you. So just to have a little extra time with a dermatologist is awesome. And I also know a lot of estheticians that might want to work for a dermatologist or that be part of their career goals. So this could inspire them to move in that direction even more.
Yeah, I think it's a great working relationship, whether we're in the same office or just in the same community. Good to have that camaraderie and being able to rely on one another. So.
All right, yeah, we can definitely support each other.
Mm-hmm.
So my first question, first question, can you tell us a little bit more about you, about what you do as a dermatologist, about your practice?
Yeah, so I've been here in Nacogdoches for 7 years now. Dermatology has been my dream. I've wanted to do it since I was very young, and that's not, I think, common. I think I was a teenager when I decided I wanted to specialize in skin, and luckily it kind of stayed that way. I love what I do. I love the visual aspect of it. I love the patients and how grateful they are when they see these changes in their skin that we're making. Mm-hmm. So it's just a really rewarding field for me.
Awesome. Yeah. I did want to know kind of how long you had the plan to be a dermatologist. So it started really young. Mm-hmm. Okay. So skin cancer. That's going to be our first question, right? Should we be looking for, since we are seeing our clients regularly, what might indicate that a lesion is potentially a skin cancer lesion?
Oh, great question. So there are 3 main types of skin cancer. The most common being a basal cell carcinoma, second most common being a squamous cell carcinoma, and then melanoma, fortunately a little less common. With a basal cell carcinoma, those are often skin colored to pink, and we describe them as pearly or even shiny in appearance. History that I get commonly when we're diagnosing basal cell carcinomas is a patient will say that they had what they thought was a pimple and they can't pop it or it doesn't seem to go away, and it's there for coming and going for months or even years. That's often how someone will describe a basal cell. The squamous cell carcinoma, those are often skin colored to pink in appearance too, and a little harder to see sometimes, but they're going to be more scaly in appearance, and sometimes they'll even be a little bit thickened. And then the melanomas often are dark brown to black, and they can be flat or they can be raised like a papule or nodule. One thing I like to emphasize to anyone who's having a skin check or to you as an esthetician or a cosmetologist is that melanomas can be flat, and that's something that you may notice when you're seeing them month to month and seeing them more often. You may see that they've got a little flat dark
it's like
spot,
just flush with the skin,
completely flat, dark, and then maybe it's bigger next time you see them. That could be signs of an early melanoma in situ, and if we're able to catch them at that early stage, that can do so much for the prognosis. So there's an acronym that we like to use to help people in recognizing melanomas, and it's the ABCDEs of melanoma. And so the A is for asymmetry. And so if you were to fold that lesion in half and one side doesn't match the other, that's that asymmetric part. The B is for borders. So if the borders are regular, that could be a warning sign. The color, oftentimes dark brown to black, but sometimes there'll be different shades of blue, gray, or red. And especially if there's a combination of colors in any one lesion, that's a big warning sign. The D is for diameter, so anything that's larger than a pencil eraser or about 6 millimeters in diameter can be concerned. And then the E is for evolution, so anything that's new or changing or newly painful or itchy, bleeding, not healing, those are all signs that we should be looking out for and things that we'd want to evaluate then.
Okay, well thanks for putting that in an acronym. We love those, really helps us remember what to look for. Okay. So moving on to papules and pustules. When do you recommend extracting versus not? And is there such a thing as over extracting?
Yeah. So over extracting, you didn't ask it, but comedonal acne, you can't really go wrong. When you're using gentle pressure and getting rid of those blackheads and whiteheads, those comedones, go for it.
Okay.
But the papules and the pustules and the nodules, you have to really be careful with, because those are the ones that can lead to scarring. So in my opinion, a pustule, I think you're safe. When you can see that purulent material on the surface of the skin, it's fine to clean, prep the skin, using a little needle to make a little nick and then gently express that. But if you're having to put a whole lot of force, then you should probably stop. And then with a papule, so it's just a red papule where you can't see that inflammation under the skin, I would leave those alone. So you're not seeing that purulence, but it's in that follicle. And so if you are to put too much pressure and that follicle ruptures under the skin, that can lead to too much inflammation, which can then lead to scarring, which is certainly what we want to avoid.
Absolutely.
In instances like that, an injection with a little bit of a steroid can be really helpful. So that's something that if they've got something coming up tomorrow, a big event, that may be something that you could send them to the dermatologist for emergently.
Okay.
One of our few emergencies.
Kinalog injection?
Exactly.
Okay. So what stage of that pimple, I guess, that's cystic pimple, will they benefit from that injection?
Really, it can be there for a couple of days. It can be there for a week. If it's something that's not going away on its own, that's when we could intervene and help it to resolve more quickly.
Yeah, because it works pretty fast, right?
It does.
Within hours, 24 hours for sure?
Usually 24 hours.
Yes, I've had a few of those, and honestly, I would say they're lifesavers.
Yeah.
So, yeah. Speaking of extracting, Amelia, why do some people have it? A lot of times I'm seeing it around their eyes, their upper cheeks, and they just have it every time I see them. What's going on there?
Honestly, some people are just more prone to developing those. We do see that sometimes it's related to products that they're using. There are a couple of lines of products where if someone comes in with milia, I ask them, are you using this product? And it's 9 times out of 10 yes. But then I've got another 100 patients that can use that product fine. But it's oftentimes products that are silicone based or some derivatives of silicone, or just anything that's too creamy or too oily. And so it may be that their eye cream is too thick for them. And that's why they're making those milia around their eyes. I really like to use some of those milder retinols for wrinkle prevention around the eyes when patients are having those problems with developing milia. Another thing that we see that commonly leads to milia, and my patients are always surprised by it because it's my older patients, and you may see this too, but they're older and they're like, why am I getting these acne bumps? I'm 75, but it's actually related to chronic sun exposure. So as time goes on, their skin, when it's sun exposed, gets a little more leathery and the collagen is not as normal and regular. And so it's harder for the skin to kind of exfoliate itself, and it's harder for those dead skin cells to be extruded from the follicles, and so that's why they'll make milia too in that sun damaged skin.
Yeah, again, that the clients might push us to extract all the milia, and some of it just really doesn't want to budge, and it really sounds like a product change there.
Yes. The retinol that I was mentioning, so a lot of times if I'm seeing that, I'll recommend that they use a retinol for a few weeks to a couple of months in the areas that are involved, and that'll make the milia easier to extract afterwards.
Okay, perfect. Good tip. This might be a loaded question, but acne. What is your approach to treating acne?
Yeah, I know that our treatments, they mesh well together, but they're a little bit different, our approaches. So there are several key factors in the development of acne. Those factors being excess sebum production and oily skin, follicular hyperkeratosis, or kind of basically dead skin that's not being extruded well, and then bacteria like Propionibacterium acnes, or P. acnes for short, and then inflammation, and then for some patients hormones as well. And so there's a whole cascade, and basically we are trying to target those things, and for different patients we're going to treat it differently. So for a mild case or a young patient, we may target that excess sebum and oil and the follicular hyperkeratosis by prescribing a salicylic acid wash. And then maybe something like a benzoyl peroxide topical might work really well for the acne, the P. acnes, and for the inflammation. For someone who's a little more severe, that's when we usually get into our prescription retinoids to treat that hyperkeratosis. We can often target that excess oil production and the follicular hyperkeratosis with something like a salicylic acid wash. And then the inflammation and the P. acnes with something like a benzoyl peroxide topical. For a more severe persistent case, we'll often transition to prescription strength retinoids topically, and then either an antibiotic topically or even orally. And then of course there are those most severe cases where we reserve Accutane, and I use that pretty frequently, especially if there's any indication that there might be signs of early scarring, because the acne is one thing, but to be able to prevent that long-term scarring is really makes a difference for patients.
Absolutely. And that was one of my questions for you. Accutane, is it really as scary as it sounds, just from the patient's perspective?
I don't think so at all. It's actually part of the reason I'm a dermatologist. I was on Accutane a couple of times when I was a kid. I took a couple of courses, and what it did for me and my skin and my self-esteem is totally worth it. I've got healthy children, tolerated it well. I've had 2 of my grown stepsons on it because I feel really safe with it. It does have to be monitored carefully and closely, but as long as all that's done, it's fine. So the things that we're looking for when we're monitoring, we're looking at labs. So we want to be checking their liver, their kidneys. We want to be monitoring their lipids. So we're checking that as needed. We're also monitoring for side effects that may be headaches, vision changes, aches, pains, mood changes, abdominal upset. And as long as we're monitoring those things and titrating the dose up or down as we see fit, then it really can be done safely. The other thing that's a big scary thing for patients is the need to be on birth control. And it can cause pretty severe birth defects, but that's not something that happens once you're off of the medicine. That's only when you're on the medicine.
Don't have to worry about it.
You don't have to worry about it later on. Yes. So we do encourage patients to be on at least 2 forms of birth control, but abstinence is an option as long as your abstinence is 24 hours a day, 7 days a week for the duration of the treatment. But being on the birth control is helpful in preventing any unwanted pregnancies during the treatment, but also it helps with any hormonal component of the acne that may be going on. Another thing with Accutane, while we're talking about it, just as their esthetician or cosmetologist, while they're on Accutane, they can absolutely still come to see you. But you just want to be mindful that their skin's going to be much more sensitive. So procedures like microneedling or dermablading, chemical peels, you'd want to avoid things like that while they're on the treatment, and usually for about 3 to 6 months after they're on a treatment.
So we'd probably be doing like some nourishing facials.
Absolutely.
Are they going to be drier?
100%. That'd be
get
great.
That moisture in the skin and just calm and soothe it. Okay, well I feel a little bit better about Accutane based on what you said. So next up, what would you like estheticians or skin experts to know about rosacea? What are some general do's and don'ts in the treatment room when it comes to rosacea?
That's so good. I bet they can be tough patients to treat because their skin is so sensitive. One thing that would be, really helpful for you all to know are some of the triggers for rosacea. So some patients with rosacea, they don't come see the dermatologist, and they may be only seeing you. And so for you to be able to counsel them and teach them what may be triggering their flares and what may be causing their rosacea to progress would be really helpful. So some of the most common ones are alcohol, hot drinks like hot coffee and tea, spicy foods, even chocolate, and then sun exposure, but we don't like the sun that much anyway.
We should all know.
So knowing those things and being able to counsel, and not every trigger is going to cause each person to flare, but letting them know what could be causing it is really helpful so they can work to avoid those things. Other things to know, they're just going to need gentle skincare. So we want them to be washing twice a day with a nourishing cleanser. We want them to be moisturizing. Sometimes they'll feel dry, sometimes they feel oily, but the moisturizer for a rosacea patient is going to be really important because it's going to help to repair that barrier that's a little bit inflammatory in their skin. And then as far as treatments, you do have to be pretty careful. Some patients can tolerate a lot of things and some patients not so much. And so if there's ever something that you're wondering if they can tolerate, maybe it's a glycolic peel or maybe it's something with lactic acid, you may want to do like a test spot in kind of an inconspicuous area, maybe on the neck. So that way you can be able to know if they're going to have a reaction. If you're going to do a test spot like that, you'll want to do it and wait about 72 hours to see what the reaction might be before you proceed with the treatment.
And where should we do the test spot?
Behind the ear and on the neck, that skin's pretty sensitive and you'll be able to tell pretty readily if they're going to have a reaction. In that way, if they do have some sort of reaction, it's not where everyone else can see.
Okay. And just to be clear, probably no dermaplaning or microneedling for these patients with rosacea.
We actually do.
Oh, really? Okay.
Yes, we do, but you might just use a lower setting with your microneedling device.
Okay.
And making sure you're being really good to moisturize after the dermaplaning.
Okay. All right. Good to know. Yeah, because it varies so much with rosacea as far as the severity of it and what they're going through. What about hypopigmentation? Is there anything out there these days that is making a difference for our clients with hypopigmentation?
Hypopigmentation can be really tough to treat. There are a multitude of causes of hypopigmentation, some of them being congenital and some being acquired over time. One of the most common reasons we see hypopigmentation in patients is actually a post-inflammatory hypopigmentation, so it's secondary maybe to eczema or psoriasis or some other sort of dermatitis, and that actually can be treated, but that would be somewhere where a dermatologist may come into play. Oftentimes we'll have to treat them with a mild steroid or even a non-steroidal topical to decrease the inflammation, and once that inflammation is in check, then we'll see the skin repigment over time.
Oh, okay, that's great.
The other common thing that we see is a little bit tougher to treat than that. It's called idiopathic guttate hypomelanosis, so a long word that basically means light spots on sun-damaged skin. So we often see it on the legs and the arms, and some patients, when they're over sun exposed, will make dark spots, some make light spots, some a combination of both. The dark spots we're often able to freeze pretty easily. The light spots can be frozen too, and so there's some room for improvement with those as well with dermatologic treatments.
Okay, and that condition that you just said, I'm not going to try to say it. Do you see that in younger patients as well, or is it just mainly older patients?
Mainly older patients, but I have some and I feel like I'm pretty young.
Oh, okay.
The other thing that actually I know do and do well would be tattooing, and that's fantastic to help with that pigment.
Yeah, there's beautiful pigments out there these days that can really match with the skin. They don't necessarily stay in the skin forever, but they can definitely be blended and create a more even looking skin tone for hypopigmentation.
I've seen really good results, yeah.
So now, melasma. Melasma, should we treat it with lasers or peels? What would you suggest, or both?
Maybe both, but first line for me is usually going to be a topical treatment. And so there are several ingredients. The kind of old gold standard is hydroquinone, which we use. You have to be careful with hydroquinone use. There's something called ochronosis that if hydroquinone is overused or in too high of concentrations can cause even more hyperpigmentation of the skin, and that's really almost impossible to treat if that develops. So usually we recommend using hydroquinone for about 3 months, and then taking at least a month off before restarting it. Other ingredients topically include kojic acid and tranexamic acid, and those have been really helpful, along with just our old retinoids that we see to help exfoliate the skin. But in regards to chemical peels and lasers more specifically, I prefer chemical peels. That's probably our second line treatment, and we are able to use those. There are newer formulations that are safe for even darker skin types, and so chemical peels are usually the way to go. And then lasers, there are a couple of lasers that will give some benefit, but several lasers that will actually cause worsening of melasma. So lasers we like a lot for lentigines and things of that nature, but for melasma, it can be pretty tricky and can cause it to worsen. So you have to be very careful with that.
Yeah, so to that point, if there's an esthetician or laser technician, they really need to know when it is melasma, because
Absolutely.
just throwing the laser on there could make it much worse.
Absolutely. One kind of good thing to look for when you're trying to figure out, is it melasma? Are they just sunspots? If it's pretty symmetric, that's more likely to be melasma than sunspots. So just something good to know.
Absolutely. What about contact dermatitis? What is the most common causes of that?
So there are several, and it's a lot of the things that you may be using and you would never even think of it. So a lot of preservatives that may be in some of the products that are used, and fragrances especially, can be a contact allergen for some patients.
Okay.
Some of the common preservative type ingredients, there's one cocamidopropylbetaine, paraphenylene diamine also can be labeled as PPD, and then sodium lauryl sulfate.
Okay.
Those are some of the most common ones that we see in our products that can be sensitizing to some patients.
Okay, so we'll definitely check the labels and make sure that's not in our products. And yeah, the fragrances, that's can be a big one. I know for me, I'm very sensitive to perfumes. So last one, keratosis pilaris. I'm seeing this on the back of arms quite a bit.
Yeah.
Is there anything that we can do about that?
There's some that you can do about that. It's an autosomal dominant type of condition, and so parents have it, they give it to their kids, and then usually you just have to grow out of it for the most part. There are some things we can do to minimize it though, and so things that we can do to minimize it include moisturizing. The moisturizers I usually recommend are moisturizers that also have exfoliating agents in them, like salicylic acid or lactic acid. There are several just over-the-counter products that work well. Urea is another ingredient that can be helpful in exfoliating those gently.
Okay, all right. Dr. Overturf, I can say personally, I'm probably going to watch this interview over at least 3 times, because you have shed some light on some burning questions that I had, and I just think there's some treasures in here. So thank you so much for sharing your knowledge with us today.
Thank you for having me.